upright or the laying down position?
Laying down.
So we're going to assess a few things. What kind of things should we assess?
Sounds. Oscillation.
What kind of stuff did we just talk about on the board?
Shape.
Shape. What's the shape of her belly? What else do we want to ask her?
How their stools are.
Bowel movements. Frequency.
Color.
Pain. Color. Do we need to poke you, or you want an upfront seat here?
I'm good. I was saying, I would say palpate for pain.
Okay. Do we palpate or auscultate first?
Auscultate.
Where do we start on our auscultation?
Lower right.
Lower right. Right lower.
Lower right. Quadrant.
7 o'clock.
Okay. You're not going to find the clocks on any of your tests. So now you need to start knowing your quadrants.
Right lower.
Lower right.
You need to be able to say lower right quadrant. Okay, it's the lower right quadrant.
Upper right.
Yes.
Okay, so your lower right quadrant. Do we want to know anything about our mobility?
Yes.
Okay. Do we want to know anything about her fluid intake?
Yes.
Okay, as well as her elimination patterns. Okay, anything about nutrition?
What's your diet look
what
like?
you've been eating? How about what stimulated this pain to start? Is it there all the time? Could you describe it? What happened? So most likely your patient will have a bowel obstruction. Okay? Now don't just come into this patient's room and go, "Hi, Miss Dawson, I'm here to put your NG tube in." She'll go, "Oh no, you aren't." Because how many people would raise their hand to have a tube put up your nose? Okay. So if that's the choice that you make on your checkoff, "Hi, I'm here to put in your NG tube," the immediate question will be why. Okay? And then you need to figure out how you're going to answer your patient's question for that. So what would be a better approach, a patient-centered approach?
Assess first.
Okay. So you're going to get a whole bunch of stuff, and this patient's going to probably say, "I'm really nauseated. I feel like I'm going to vomit." Okay. Well, let me sit you up just a little bit. So let's have you sit up. Can you vomit into the pink bucket? Okay. It's highly possible they will have vomited before you came in, and there might be some vomit for you to examine. Okay. Well, you have two sets of orders. You can put down an NG tube, or you can treat your patient's nausea. Okay. What would you rather do?
Treat the nausea.
Okay. So you treat the nausea. And your patient's still in pain. So when you treated the nausea, were you treating the cause or were you treating the symptom?
Symptom.
Okay. So what could you do to treat the nausea and the pain at the same time? Nausea medicine will take care of nausea. Pain medicine will contribute to the problem, won't it? Yeah. Because it will continue to slow down the intestines. What's causing the problem here?
The obstruction.
As a result of the obstruction, what's happening? Inflammation from fluid that's hitting the obstructed site, right? And it's irritating it. So what would be a better choice? Because now are you treating a symptom or are you treating a cause?
Cause.
Do you guys see that as a nursing question, test question? Are they both appropriate nursing answers? Well, what's the best answer? Treat the cause. Don't just treat the symptom. If you treat the cause, do you think you'll alleviate the symptoms?
Yes.
Does that make sense? Okay.
I think we should have like a worksheet where a lot of these questions are. Well, being able to identify the cause, because a lot of people said treat the medication, so obviously we didn't know it, so we cannot.
Junior, this is why it's an experience. It's okay.
As a student would say, look in the book.
Rude. Stu would say, look in the book, there's a nice worksheet in there, all written out with some other verbs, but it's good. No, that's the whole reason we're having this discussion right here, so you guys can think that thing through, rather than at a checkoff. Think it through now. Because what if you do, at the checkoff, walk in and say, hi, I'm here to put in your NG tube, and the patient says, I don't think so. How do you backpedal on that?
Let them explain why.
How it's going to make them feel, how it's going to improve the condition, and they'll be a little bit more willing to do it.
But what do you need to know first?
What's it costing?
How do you
What your
feel?
cost, yeah.
That's right. So it's not the case of, okay, the doc ordered an NG tube and this is my check-off day, I need to stick down an NG tube because I know that's what my skill is, okay? It's the case of, the doc has ordered an NG tube, does my patient need an NG tube? Does that make sense? Okay? So you find out if your patient needs the NG tube, and then you help them understand why it's important to be invasive. By putting this down, here's what we're going to do. We're going to remove the substances that are in your stomach, which will relieve the pressure on the obstruction going on in your bowel. And that should reduce the pain as well as the nausea. After we get this down in there, if you're still feeling nauseated, I'll be more than happy to give you nausea medicine to help you feel better. Does that make sense? And then you make an agreement with your patient on how to handle this NG tube. People do not want this in. This hurts. Now, obviously, don't say, oh my gosh, this is the most painful thing I could possibly do to you. They'll be like, I'll pass. Right? Yeah? Okay. This is going to be very uncomfortable. So it's going to be really, really important that you don't pull on my arms. Okay? And I would like to use a signal. If you would like me to stop what I'm doing, please just raise your hand. Okay? And I will stop what I'm doing. But I will also explain to you everything I'm doing as I'm going along with this procedure. Okay? Okay. So I want to know if you've had any facial trauma, surgeries, deviated septum. Why would that be important to know?
Yeah.
They could be have abnormal structure.
That's right. Which was bigger, which was abnormal? Could there be a problem? NG tubes ended up in people's brains, okay, because of issues. So it's kind of a cool x-ray. That was the only time I've ever seen that x-ray. I never wanted to see that one again. So you're going to use your pen light. You're going to assess their nose. You're going to ask them to blow out of one nostril and then the other. So you're going to determine which nostril we're going to go with. So Paris, which nostril would you like this NG tube in?
My
Right.
right.
Oh, that's so convenient. All right. Do you mind if we remove your glasses? All right. So we're going to remove your glasses.
Please, they're Gucci.
Okay. So the mannequin is limited in its mobility. The mannequin cannot tilt its head back, nor can it tilt its head forward. Our big guy downstairs, he sure can, can't he? Right? So downstairs, when you put in an NG tube, you can measure just fine, but you're actually not going to hit your measure just because of the limitation of the mechanics within them. For here, wherever you measure to, you can actually reach that. This won't stop. Okay? Now, you cannot measure placement over the gown. You can't. Because you have to determine that the placement is at the xiphoid process. Can anybody see this patient's xiphoid process as is?
Nope.
No, we do not palpate the xiphoid process through their gown. So we're going to say, we need to kind of lower your gown just a little bit. Okay? Are you good with that? Yes, I'm going to bring you up to a nice high Fowler's position. Sitting up is the best position to be in for this skill. Not a 30-degree angle, not a 45-degree angle. We want to be in full high Fowler's for this. All right. I'm going to get my tape ready now, because as soon as this gets going, we're going to get on a GUI.
It's gonna be the worst video ever.
So I'm going to go ahead and pull down your gown just a little bit. Okay. And I'm just going to measure for placement.
Straight at you.
You want to measure from the tip of the nose, to the earlobe, to the xiphoid process. Okay? You're going to mark it, and you're going to put a piece of tape in. When you're done with your skill, you're going to remove your piece of tape so that your classmate can put a new piece of tape. Okay? Now, why do you think it would be better to put tape as opposed to using a nice ballpoint or some sort of black marker? Very easy to see. It's easy to stop it. And you're going to get very gooey when you do this skill. Okay? So you get some nice KY on there and you've just lost your marker. You need to mark it. If not, you don't know where to stop. Okay? Okay. So I'll bring it back up and cover it up. Alrighty. So there's going to be a point in this skill where I'm going to need you to take a sip of water, okay? You up for that?
Yeah.
Alright. So what I'm going to have you do first is I'm going to have you tilt your head back and I want you to stare at the ceiling. Okay? Why do we have them tilt their head back first? How so? What does it do?
It opens.
Is it an issue of opening the airway or straight shot down to the pharynx?
Straight shot.
It
Yeah.
straightens it out because we're nice and curved. You go back like this, we straight shot it right back. Okay? You're going to start feeling this tube at the back of your throat. At that point, it's important that you indicate. Can you just raise a hand and indicate that you feel it at the back of the throat, or just say, I feel it at the back of the throat?
Yes.
All right. Okay, at that point, I'm going to have you then tilt your chin forward, and I want you to touch your chin to your chest. Can you all do that, you guys? Take a deep breath while you do that. What happened?
It's tighter.
It's tighter, isn't it? So what's the reason for having them touch their chin to their chest?
Make sure you're not esophagus.
Close the larynx.
And it closes what?
Larynx. Pharynx.
It's a straighter shot to the esophagus, and it makes it very hard to hit into the airways. Okay? Does that make sense?
Yes.
Yeah? You guys saw that when you went and tried to breathe? Okay, we kind of impeded your airway a little. Okay. So I would lube this up. Okay, not actually going to lube it, right?
Right.
Okay, if I need to lube it, I'll use mannequin lube. Okie dokie. Ready for this? We got our little water here. Okay. As ready as you'll ever be? Yes. Okay, I want you to tilt your head up and look at the ceiling now. Here we go. Okay? Patient's probably going to go, ah. Okay. You feel that at the back of your throat?
Yes.
Yes? Okay, what if my patient immediately started going, do not pull it out. Because if you pull it out, you have to do this poor little thing again. Okay? But pull back until they relax. Do you think your patient's tears are going to be flowing and flowing? Oh, yeah. Pull back. Okay, you're breathing a little bit better? Yes. Yes? All right. Okay. Still feel that at the back of your throat? Yeah? Okay. Now I'd like you to go ahead and sip your water. Put your chin to your chest. Okay? And every time you take a sip, I'm going to push this thing forward. Now why do I push forward as they're sipping?
Helps glide it in.
It helps go in. Okay, so take a sip, slide. Sip, slide. Okay? If they start going, what do you do?
Pull it up.
Pull back till they stabilize. Okay? Try it again. Sip, and while they're sipping, you slide. Sippy, sippy, sippy. Okay, we've reached the level of our tape. I think that's a seriously do something about your hair here. Okay. Now I need to determine placement. And I want to make sure it's not going to slip out. So I'm going to tape it to their cheek. Okay? Now what you're going to see in older nurses do, okay, is to put air in. Now this tube's pretty long, okay? So maybe a good 30 cc's of air. Should take it all the way down in the stomach. So what I could do is put my stethoscope down here. What quadrant do I want to put my stethoscope on?
Right, left.
Which one?
Look.
Upper
Yeah,
left.
stomach.
That's right. Where's this thing at?